Good morning, everybody. So I am Susan Tortolero Emery. I'm the Senior Associate Dean at the School of Public Health, but a former director of the Center for Health Promotion. So I love being back here and being able to do the welcomes. So on behalf of Dean Borwinkle and the Dean's Office, I welcome you to the McGovern Lectureship, sponsored by the UT Health School of Public Health, Center for Health Promotion and Prevention Research. We are honored to have all of you here today and all of you online as well, which we can't see here, but I know you're out there. The John P. McGovern Award Lecture Series in Health Promotion was established in 1996 by our former dean, the former director of the Center for Health Promotion and Prevention Research, my mentor and friend, Guy Parcel. Dr. McGovern's generous gift to the Center for Health Promotion and Prevention Research to establish the lectureship acknowledges the center's vital role and leadership worldwide and the center's contributions to developing, implementing, and evaluating health promotion programs. The lectureship has recognized 27 trailblazers and distinguished researchers in our field. If you review the recipients, it's the who's who in the field of public health and health promotion. So many of you who are students, you have read many of these distinguished researchers' work and textbooks that you are learning from. From Larry Green, who was the inaugural lectureship, who gave the inaugural lectureship, to Carlo Di Clementi, Marty Fishbein, Albert Bandura, Meredith Minkler, and many, many others. Dr. Fernandez is going to introduce our distinguished recipient today, but I'd like to provide a warm welcome from Dean Borwinkle and myself. The dean could not be here today. Interestingly enough, he is in Boston while Dr. Galea is here. And he sends his warm regards and respect to you, Dean Galea. Just want to say, from the perspective of being part of the associations of schools and programs of public health and going to the dean's meetings, to provide my perspective of Dean Galea. He is probably one of the most well-respected deans in the country. He is a prolific writer, a bold advocate, inspiring schools of public health leadership across the country to think strategically and really to tackle the most complex health problems like gun violence, mental health, migrant health, and so forth. Your leadership at Boston University is a model for all of us, so thank you for that. Again, thank you for joining us today, and we hope you find this event most both inspiring and enlightening. Thank you.
Good morning, everyone, and thank you so much for coming today, and for those of you who are here in person for braving the rain. And by the way, Dean Borwinkle also wanted you to know that it's a beautiful day in Boston. So sorry we couldn't match that here in Houston. So I'm Maria Fernandez. I'm the Vice President of Population Health and Implementation Science at UT Health, and I'm also the Director of the Center for Health Promotion and Prevention Research. So Dr. Galea is a physician, epidemiologist, and author. He's the Dean and Robert A. Knox Professor at Boston University School of Public Health, and he's previously held academic and leadership positions at Columbia University, University of Michigan, and the New York Academy of Medicine. He's published extensively in the peer review literature and is a regular contributor to a range of public media about the social issues of health, mental health, and the consequences of trauma. He's been listed as one of the most widely cited scholars in social sciences. He's also the past chair of the board of the Association of Schools and Programs of Public Health and the past president of the Society for Epidemiologic Research, and also of the Interdisciplinary Association for Population Health Sciences. He's an elected member of the National Academy of Medicine. He's also received several Lifetime Achievement Awards. He holds medical degrees from the University of Toronto, graduate degrees from Harvard University and Columbia University, and an honorary doctorate from the University of Glasgow. So it's my distinct pleasure today to present the John P. McGovern Lectureship Award to you, Dr. Galea. I'm going to just hand it to you.
Well, good morning. Thank you for that super kind introductions. What you didn't hear is that there's a law of stability in nature. You need the same number of deans in the same physical place, which is why Dr. Borwinkle and I switched positions, because it would result in an instability if deans in different places. It's really a pleasure to be here, and I'm really honored by the welcome and the kind words. And also, I've really enjoyed meeting a number of faculty and students of your excellent School of Public Health, and to look at the people who have received this award in the past. It's really a privilege to be among them, and I'm very grateful to Dr. Fernandez for sponsoring the center, sponsoring the award. So really, thank you for having me here. So I'm going to talk for about 30, 40 minutes about sort of the notion of reimagining prevention in line with the theme of the award in the context of post-COVID. And I will make some framing comments about COVID and then move to where I see us heading in prevention. And I'll say some things which I think you'll all agree with, and I'll say some things that you may disagree with, and then we'll move on to questions, so you can actually we can have a conversation about the things that on which we may disagree. I'm going to start with so the people online heard nothing of what I just said. So what I was saying was that everybody who's joining online, I understand, is the cream of the crop and the best, smartest people around here. But you missed all that. Okay. So I'm going to start with, why should the pandemic change anything? We're sort of in the now officially post-COVID moment. And one of the temptations of the post-COVID moment is to say, oh my good God, I never want to talk about COVID ever again. So I realize that there's a bit of a peril in putting COVID in my title, but I want to start with a simple argument that I actually think that it is unavoidable, inescapable, and in fact, wouldn't be fulfilling our responsibility to not talk about COVID. So let me start with this. So this is global life expectancy in the context of COVID. What you see is sort of this tremendous drop starting in the beginning of 2020 and only starting to recover in the middle of 2021. Another way of looking at it, this is global life expectancy. And what you see is this sort of hockey stick inflection. Essentially, COVID put global life expectancy back about 10 years, which is quite remarkable. There are many things that were remarkable about COVID, but essentially the decrement to global life expectancy, broadly speaking, that we saw in COVID, we haven't seen in the world in 100 years. It really takes us back to the 1918 flu pandemic before we had these kind of consequences. These consequences were felt worldwide. This is average change in life expectancy worldwide. You see the sub-Saharan Africa is gray because the data there are very unclear. There's a whole other set of conversations about what actually COVID did in sub-Saharan Africa, which we can discuss. And of course, all these COVID consequences, we all know, were lived immensely unevenly. This is US life expectancy. The black line in the middle is the overall drop in life expectancy in the US, which is about a 2.5-year drop. The purple line at the bottom is the truly extraordinary and horrifying 6-year drop in life expectancy among Native Americans. And that is really quite amazing. Like a 6-year drop in life expectancy is really unheard of. Just to give you a comparison, was about a 3-4-year drop in life expectancy among young men during World War II, young men who were being sent off to war. And this is a 6-year drop in life expectancy. We've had drops in life expectancy over the past 100 years since the 1918 flu pandemic. Those drops in life expectancy typically are in the 0.2, 0.3 range. So a 6-year drop in life expectancy is like just utterly unprecedented. So not only was there this impact on health worldwide, there was impact on health domestically, and there's a very uneven impact on health domestically, affecting people of color more than other people. And as I'm going to talk in a second, affecting people on all sorts of identities as marked by marginalization. And then, of course, there's a whole other set of consequences of COVID, which are outside of health, but which will eventually have health implications, including, for example, the lack of attainment of educational attainment. So this actually looks at education over time, and the black line on top is the overall historical average, and the gray line is students in majority Black schools, historical average, and the blue line are students in majority Black schools during COVID-19. Broadly speaking, most assessments of the educational achievement during COVID have that students in K through 12 lost about 6 months of education, which will not be made up, which means that we'll have a whole cohort, a 2-year cohort of students who are going to be going through life now with less education than they otherwise would have, which has all sorts of other health implications. Okay? So that's COVID. Now you roughly know all that. So now I'm going to move on to, okay, so what caused these problems? Because in order for us to understand how post-COVID we can actually reimagine prevention, which is the title of my talk, we need to understand actually what happened during COVID. And at some level, some level I'm not telling you things that you don't know, you haven't thought about, but hopefully I'm organizing them in a way that's actually helpful for us. Because I think despite the mess of bad stuff that happened during COVID, we can distill what happened during COVID into 3 things, into 3 key problems. Problems with our social structures, problems with our health, and problems with our investments. And I want to talk about each of them very briefly. So let me start with our social structures before the pandemic. We had built a society where groups who had less advantage to begin with are predisposed to accruing even more disadvantage when something bad happens. It's actually as simple as that. I'll start with a very concrete, simple example, which is new pandemic hits, right? It's March of 2020. Everybody panics. Everybody says infectious disease, bad, 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 right? Infectious disease, everybody says, how is that transmitted? Well, it's transmitted from me to you and you to me, right? And everybody says, well, how do we stop that from happening? Well, you and I not to get close to each other. So everybody stay home, right? That's what happened, correct? Makes sense? Yes? Logical? Yes? Now, here's something that we knew before the pandemic. These are data from before the pandemic, from the Bureau of Labor Statistics. Among people who work, these are by quartiles of income. On the far right, you see that people in the top quartile of income, 62% can work from home. In the other quartiles of income, only a minority of people can work from home, right? So what's going to happen if you say work from home? Well, the 75% to the left are at greater risk, right? So let me go back to what I said. New pandemic hits, infectious disease, transmitted, you to me to you. It makes sense, right, to say, let's stay away from each other, let's work from home. To which I say, does it? Because said another way, what you're saying is, new pandemic hit, infectious disease, transmitted, you to me to you. Let's do the following. Let's those with privilege protect themselves and everybody else take more of a risk. Now, I know when we think about this, and I hope you don't mind, I'm going to try to make us a bit uncomfortable in this talk, because we are in public health and we think of ourselves as being on the side of the angels all the time. But if I may just challenge that just for a second, bear with me, just make it worth your while to be here. Okay, raise your hand if you work from home at least part of the time during the pandemic. Okay, put your hand down. Everybody's okay. Raise your hand if when you worked from home during the pandemic, you never got anybody to deliver anything to you. Be it Amazon, be it groceries, you got no deliveries. 1.5 people, maybe 2 people. The rest of us, we got delivery. So let me ask this question. Why was it okay for us to protect ourselves and to get people who probably made less money than we did, and more likely people of color, to deliver stuff? Because we knew they were taking a risk in doing that, right? It's hard to take, right? It's like it makes you feel really uncomfortable when you say that. But that is what we did during the pandemic. So we knew this, right? This is pre-pandemic data. This was available to all of us. So when we said, oh my God, pandemic coming, we're afraid we might going to die, let's all of us stay home, what we essentially were saying, let's stay home so other people don't stay home and deliver stuff to us. And this, right, hopefully you all see now why I'm starting with COVID. But if we're serious about reimagining prevention, we need to say to ourselves, if this happens again in March of 2020, relived, right? Maybe we shouldn't be saying that. Maybe it's not the rational thing to do to say, new pandemic infectious disease, let's all stay home, because it's not true that we can all stay home. And by doing that, we are actually increasing health gaps. And that is exactly what happened, because look who died in COVID. This is that each square is like the size of people who died. But who died are construction workers, drivers, bus drivers, manufacturing workers, counselors, laborers, material movers, cooks. Those are the people who died, because those are the people who actually were exposed to COVID. And of course, those people are disproportionate to people of color. This simply looks at Black workers, although you can actually look at different things for Latino workers. But Black workers are more likely to be frontline workers. You see 17% versus all workers, and more likely to be grocery store workers, public transit workers, trucking workers, et cetera, which are the groups who died. So reason number one why COVID was the way it was our social structure, okay? Reason number two, our health before the pandemic. So again, we knew before the pandemic that we're not healthy. And we also knew before the pandemic hit this country that the pandemic is going to hit people who are unhealthy worse. This is data from the China CDC in February of 2020, before there were any known cases in this country, okay? So look, risk of dying. If you have cardiovascular disease, 10%, diabetes, 7%, respiratory disease, 6%, et cetera. In other words, we knew that people who are sicker are more likely to die in COVID. And of course, we are sicker as a country. This is before COVID, all the way to 2015. We have 5-year less life expectancy than other high-income countries. Essentially, we choose to die 5 years earlier than other high-income countries. I could ask you for a show of hands as to how many of you voted to die 5 years earlier. I bet none of you actually did, but that's a choice that we make as a country, which means we are sicker than we need to be, which means, of course, when the COVID hits, which is, by the way, affecting people who are sicker more, we die more than other countries, which is exactly what happened. This looks at countries in terms of life expectancy in COVID, and we are at the bottom. You have US total, US Black, US Latino, and you see we die more than do other countries, okay? And by the way, again, our poor health before the pandemic was not evenly distributed. And similarly, the consequences of COVID are not evenly distributed. So this actually looks at income. If you look at the yellow bar is illness before COVID that makes you more vulnerable to COVID. And the x-axis is income decile, higher income on the far right. You see, the more income you have, the lower the yellow bar, which means the more income, you are less likely to have illness that makes you vulnerable to COVID. The green bar, by the way, is having prior mental illness that makes you more vulnerable to poor mental health after COVID. I'm not going to talk about mental health very much, but also follows the same pattern. So in other words, before COVID, right, our health was patterned by sociodemographics. The more income you had better health, which means you are less likely to suffer adverse consequences from COVID. And that is also racially patterned. You look at high blood pressure, diabetes, an example. Blue bar is Black, red bar is white Americans. You see higher high blood pressure and diabetes among Black Americans, young ages, middle ages, older ages, which of course then translates into higher risk for adverse consequences. So reason number two why we did so poorly about COVID is that our health before the pandemic predisposed us to what happened in the pandemic, including, for example, the disproportionate mortality rate among Black Americans compared to white Americans. Here you see the drop in life expectancy among Black men, for example, by comparison with white women on the far right. And that is a direct patterning of our underlying health before COVID. Reason three is our investment. So what could have helped us in COVID? Well, what could have helped us would be investments in the practical work of public health. Public health is ultimately what protects us against infectious disease. But what we had been doing is we had been systematically disinvesting in public health. The public health workforce has been shrinking over the past couple of decades, which means coupled with our underlying social structures, coupled with our underlying poor health, we as a country were sitting ducks. We had made ourselves vulnerable, and we had removed our ability to protect ourselves. So with all these pieces together, it is no wonder that COVID was the disaster it was. We actually created that. We actually created that problem. You know, and this is exactly what happened. I mean, this is, we are the darker line. The other green lines are high-income countries. We actually had, we vaccinated less people than all other high-income countries, for example. And when we did vaccinate people, we actually vaccinated more people who did not need it as much. This looks at the top row are the most vulnerable counties. The bottom row are least vulnerable counties. And what you see is that the least vulnerable counties have higher vaccination than the most vulnerable counties, which is exactly the inverse care law articulated way back 52 years ago by Julian Tudor Hart. People who need care the most are the ones who get it the least, which is exactly what we did in our country. And we did a terrible job with communication at multiple levels, which we all know about. I'm not going to spend much time on. And of course, we allowed to happen then things like this, the overdose epidemic, which was surging, right? Which actually we had gotten a bit of a grip on. You see it in the late 2019, 2020, and then it surged again to more than 30% increase in time of COVID. I'll give you just one illustration about, for example, how much attention I think the opioid overdose epidemic deserves that we don't give it. I'll give you a data point. Since the beginning of the COVID epidemic, more people have died from opioid overdose deaths than people under 65 died from COVID in this country. So just, the math is the math. About 300,000 people since the beginning of the COVID pandemic, and you can look this up, have died of opioid overdose. Under age 65, about 250,000 people have died from COVID. So since the beginning of the pandemic, under 65, more people have died from overdose than died from COVID. And this reflects, of course, our underlying poor ability to handle these underlying epidemics because we haven't dealt with them before. And as COVID happened, here's something which I find sort of interesting. For example, despite the fact that we're all locked away and driving less, we actually managed to increase our deaths from road traffic accidents during COVID, while all other countries actually decreased them. And that, of course, again, reflects our underlying disinvestment in simple things like actually road traffic safety. Okay, so COVID, what happened? Why it happened? So what do we learn from COVID? Well, I would argue that the simple lesson to learn from COVID is it's not about COVID. This is, by the way, a picture, a painting from 14th century about the Black Death in Europe, which killed about a third of European residents at the time. And it really wasn't about the pandemic. I mean, yes, there was a virus, but the virus ultimately intersected with the world underlying world around it. By the way, anybody who's interested in this part of my talk that I've given so far, my book, The Contagion, next time really talks about all these forces, about how these underlying forces resulted in what happened in COVID. I think if the pandemic showed us anything, it's this: the problems of any of us are the problems of all of us, that we actually were all interlinked. We should have known this before, but our underlying conditions created problems that we have all experienced. One of the challenges I think we have as a country, one of the challenges we have in public health is it's hard to convince people about, for example, the importance of health inequities, which I'll get to in a second, because even people who are good people, think of themselves as good people, think of themselves as charitable people, can't help but think, yeah, but it's not my problem. At least I'm doing okay. I may care about the fact that they, using the word they intentionally, are not as healthy as I am, but really, it's not really directly my problem. But what the pandemic showed us is it's actually all our problem. Now, we should have known this from before the pandemic. For example, cost to US employers and things like diabetes, it costs about like $90 billion a year from cost to things like diabetes. And just to show you one piece of data point about showing how much our underinvestment in health matters to all of us, one of the health indicators that everybody here knows we do terribly on as a country is maternal mortality, right? So maternal mortality, this is our maternal mortality per 100,000 births. So what you see is we're about 4 times higher than all other high-income countries. This is well known. There's been quite a few articles in mainstream media about this recently. And I bet you have this conversation with your friends who are, because we all swim in privileged circles. People say that's terrible, and people will acknowledge that it's terrible, and particularly terrible because it affects particular groups worse, and it's very bad. But at the end of the day, in their head, they're thinking, well, at least it doesn't affect us. So what I actually like about this analysis is then they didn't just look at the US overall, they also looked at the richest 1% of counties in the US and white Americans. Maternal mortality among the richest, in the 1% richest counties is still twice as high as it is in all other high-income countries. So our underinvestment in health, our underinvestment in social structures that generate health affects all of us. And the COVID pandemic should have taught us that, which makes a strong practical as well as moral case for centering health equity. So that's COVID, why COVID happened, what COVID should teach us. So now let's get to prevention. So how do we reimagine prevention in a post-COVID world? And I've given sort of some of this already away, but I want to just talk about 3 things. I could talk about a lot of things about how we can reimagine prevention. I want to start with equity. I want to move on to science, and then I want to sort of make us uncomfortable again a little bit by talking about us and how we do our work and talk about some self-awareness. So let me talk about each of them. I'll start with equity. So, we in public health it's comfortable for us to talk about health equity. It's something that is at the core of public health. It is sort of we teach it our students. I think it's sort of it informs those of us who choose a career in public health. But I do want to make the point that I actually think centering equity is difficult. It is actually difficult, and it is uncomfortable, because when you think about it beyond the superficial, you realize that to actually get to health equity, you need to make difficult decisions and think about difficult things. Now, why is that? This is a definition that we just published recently. What is health equity? Health equity is about the allocation of resources according to need, such that preventable differences in health outcomes are minimized. Now, that sentence is one of those sentences that you can all look at and say, yeah, I agree with that. But the first part of that sentence, allocation of resources according to need, that's a really difficult sentence, right? Allocation, like, what's that mean? It means making sure that people have resources according to need. Let me ask you this question, is that true? Like, are resources currently allocated according to need? I'm not so sure. Let me show you just a couple of data points. This is global, the global lens. Income is on the left, wealth is on the right. The red bar are the richest 10% of global citizens, us, by the way, right? We control 50% of world's income. We control about 80% of the world's wealth. That directly translates into this. This is life expectancy globally. This is pre-COVID, where life expectancy in this country is in the high 70s, 80s. Life expectancy in Nigeria is about 54 years. So our life expectancy, leaving aside COVID, right, is 25 years more than Nigeria. Let me ask you this question. Raise your hand if you think you deserve to live 25 years more than a person who just happens to be born in Nigeria. Don't deserve that, right? This is simply global geographic good fortune, that we happen to be in a place where we have the resources to make us healthy. So if you buy the definition that help to achieve equity, you need assets distributed according to need, there needs to be some asset, I'm going to choose the word carefully, redistribution. And that is very uncomfortable. Several of you have done work in low-income countries, and we're sitting in a nice auditorium, nicer than in many low-income countries. What does that mean? Does it mean that we should sit in a less nice auditorium? Do you want to sit in a less nice auditorium? Do you want to not have air conditioning? Right? And these are difficult questions. And, just like it's a difficult question, when I made us all uncomfortable by saying, infectious disease hits, transmitted me to you, everybody stay home. Makes sense, right? But the next part of that sentence is everybody stay home, so those who can't stay home will die more than those who do stay home. Are we willing to say that? It's a difficult question. It's a difficult thing to say. So when I say centering equity, I'm saying it to push us to think these things through so that we are ready when things happen that require us to act quickly, and we can think carefully about the implications for all of us. Because the problem of one of us is the problem of all of us. And I think thinking of prevention, reinventing prevention looking forward, that should be at the core of what we do. This is globally, just taking a US lens. Here's the US lens. The top 25% of income earners have had their income increase over the past 40 years. The bottom 75% of wage earners have not had really any appreciable gain in income in the US. That's the bottom. But by the way, there's also the bottom 75% are the people who can't work from home. Remember that? Same thing. By the way, also overlaps with people who, broadly speaking, don't have a college degree, which is none of us in this room, right? So we should just be clear about that. Those are the people who are holding the resources, the assets that make us healthy versus everybody else. Have enormous life expectancy gaps in this country. There's about 20-year gap in life expectancy. And, I think all of this, I find this one data point really gripping. This is neighborhood opportunity, like being born in different neighborhoods. If you're born in a high opportunity neighborhood, you actually have a 7-year greater life expectancy than if you're born in a low opportunity neighborhood in this country. Sometimes when I speak to lay audiences, because people, I talk about health and people don't listen carefully, they will ask me the question about what can I do to be healthier? And the answer is very simple. What you really need to do is you should choose to be born to well-off parents in a good neighborhood. If you choose that, you can be fine. Don't worry about it. Everything else will fall into place. That's what you should be doing. And it shouldn't be like that. It shouldn't be like that. We talk a lot appropriately about black-white health gaps. We talk a lot about that. It's appropriate we do, because there are these black-white health gaps. I don't think we can have that conversation separate from the asset gap between black populations and white populations. And just to show you that in one slide, look at the bottom right panel. The bottom right panel, the baby blue, I don't know what the color it is, slightly colorblind, is white Americans. The darker purple is black Americans. Okay, so life expectancy, higher among white Americans than black Americans. We all know that. But look at the other panels. Higher unemployment among black than white, higher college education white than black, higher household income white than black, higher home ownership white than black, higher incarceration black than white. So actually, given the other 5 panels, it would be shocking if the bottom right panel was any different, right? The bottom right panel is directly linked to the other 5, which means you can't really talk about the bottom right without talking about the other 5, which of course means that public health needs to be front and center about dealing with these other 5 panels, because talking about the other, trying to talk only about the bottom right panel without talking about the other 5 pushes us in absurd directions of saying maybe there's a magic pill that's going to narrow these health gaps. Of course there isn't. It is all about these other 5 things. But that means that we need to think about what global health equity means in a world where health actually is equitably distributed between and within countries. So number 1, we should center health equity. Number 2, better science. Now I'm going to get into the parts where we look inward a little bit, just to make it comfortable framing it. Perhaps one of the least felicitous slogans that emerged during COVID that many of us in our circles endorsed is "Follow the science." If I had the courage, I would write a book with the word called "Follow the Science" with a line straight through it. Follow the science is a reductionist approach to the complexity of the world. It suggests that science results in clear binary dispositive outcomes, and it suggests that science is divorced from values. That is a mistake. It is a mistake that we made during COVID, and it is a mistake that earned us popular loss of trust, because people intuitively recognize that scientific decisions are not the only decisions that should decide what we do. Let me tell you a scientific decision. You should never drive your car at faster than 25 miles an hour. Because if you drive at 45 miles an hour, your chance of dying in an accident is 3-fold. I won't ask you to raise your hand. Everybody here has driven at more than 45 miles per hour because it's part of our speed limit. Follow the science would say there should be no speed limit over 25 miles per hour. Why don't we do that? Why aren't we out there right now encouraging populations to say all speed limits should be under 25 miles per hour? We don't, because actually we don't mean it. We don't mean follow the science. And in COVID, we tried to push that on populations, and populations correctly pushed back. So this section is about us and how we did our business. Part of it should be, we need to make sure that we are honest about how we approach things with populations, and we have the wisdom to say, not just about science, it's about values, and it's about the combination of the two. Now, there are people who are writing about this. There's the good news. There are scientists who are writing about this. This is from Parkhurst, who's written actually a very nice book about this, talking about the kind of evidence that we need that is ultimately evidence that is responsive to policy concerns within local contexts and that addresses the policy concerns of the moment. And there are schemas like this, like to build popular trust, you need technical capacity, yes, which is what we bring, but you also need political will, and you need to engage communities. So, follow the science suggests that we can get people to trust us just with the top left corner. Nobody's going to trust us with just the top left corner without also engendering political will, without also engaging communities. And that, by the way, means the super sticky, messy work of engaging people who we disagree with. That means the super sticky work of dealing with people who have thoughts that have been distorted by false social media narratives. It is not trying to steamroll them, but actually trying to bring them around to how we're thinking about everything. It also means, by the way, this kind of work, it means work that allows us to use data from multiple sources to better understand people, to better understand what we do, to better understand decisions we have to make. Just to make a small detour into data, because I think it's actually important in terms of the science that we do. I had the privilege of leading a commission last year that looked at better approaches to data to promote health equity. And what this slide shows you is the red circles are novel forms of data. The bluer circles are more traditional forms of data, talking about the fact that we actually need to get more comfortable with bringing data from multiple sources to inform our thinking, going all the way from social media to satellite imagery to EMR, coupled with our typical census approaches, vital records approaches. And typically what we have done for decision-making for health is you have this funnel, all sorts of data compete with each other until you get to a simple point. And to move to the right, which is an ecosystem of all forms of data that is evolving and it is constantly sensitive to changing moments. I mean, certainly one of the things that I think clearly emerged that was a mistake during COVID is that we said things as though they were unchanging, when in fact the data change all the time. I recently had the privilege of doing an interview with Director Walensky, is the head of CDC, which is actually online. You can see it. My first question to her is, what do you think was went wrong during COVID? And without thinking for a second, her answer was that we didn't communicate well. And part of that miscommunication was actually we communicated false certitude, saying this is the answer, and it's the answer, when in fact, the answer changes all the time as the data change. And we need to get much better at that. Anybody who's interested in this and interested in thinking about data, how data can be applied to prevention and health equity, this is the number of principles in the report, and it's cited over here, which you can look at. And just to make the point that although this is an audience that actually understands that we need multiple sources of data that characterize the full context of people's lives to understand health, the rest of the world really is still quite far behind from understanding that. This is from a survey that we had done asking people what primarily causes your health. What you see is that 25% of people say healthcare causes their health, is the most commonly mentioned. Only 3% of people mention politics is affecting their health. If you ask me, I would flip that. Politics affects our health more than anything else, which just shows how far we have to go in the population. So point 2 is doing the science. And point 3, which is the hardest point, is self-awareness. I actually think that this is a moment of being aware of the mistakes that we make in science. And this is the part, the slightly icky part. And I'm saying this because, look, COVID was a tragedy. 7.5 million people in the world died from COVID, probably an underestimate. 1.2 million Americans died from COVID, probably an underestimate. It resulted in a drop in life expectancy, 2.5 years, drop in life expectancy among Native Americans, so 6 years, among Black Americans, about 3.3 years. These numbers unheard of for 100 years, right? It is a tragedy. It is even more of a tragedy. Those of us in public health, this was entirely our remit. If we don't hold up a mirror to ourselves, if we don't genuinely hold up a mirror to ourselves and say, what did we do wrong? Okay? And I think to do that, we need to be ready to ask difficult questions about what it is that we did. So zero COVID. Zero COVID was a notion that emerged from public health. A small medical journal called The Lancet published an editorial about making a case for zero COVID. Zero COVID was never remotely feasible. We have eliminated only one disease ever, smallpox. And that disease was not transmitted also in animals. There were no animal reservoirs. There was never any chance that we're going to eliminate COVID. But at the same time, public health jumped on this. Yes, we can remove COVID. We can remove COVID because we're following the science, and we can lock everybody in the home, except, by the way, the 75% people who can't afford to be locked in their home, who are then going to deliver stuff to us, and we're going to eliminate that. And of course, that kind of logic, now you can laugh and say, well, okay, fine, that was just a hypothetical idea. It wasn't a hypothetical idea. It was taken up by a small country of 1.4 billion people, of China, who adopted the official policy of zero COVID, shut everybody inside, had all sorts of people dying because of the unanticipated consequence of that, and fundamentally used as an excuse by a particular regime to advance its particular political agenda. And that, by the way, was done in the name of public health, which means that we in public health should say that that shouldn't be done in the name of public health. COVID was a terrible moment. I've said this time and time again, but it wasn't equally terrible for everybody. Who was it not terrible for? So this is from a survey in 2020. And each of these bars, they're mental health, personal finances, job security, take-home pay, physical health, personal life, work-life balance, okay? Below the line means you're doing worse on those axes. Notice there's one particular cluster where everybody's doing better. You see that right there in the middle? Now look at the axis who that group is. That group are people with postgraduate degree. That's us. Because you know what? Yes, it was scary. And yes, we all had our problems. But, we could spend a lot more time at home. And we didn't feel that unsafe. But we actually did okay. Now, I would ask you this question. Really, look in our soul. It's really difficult to come up with recommendations from public health when we actually were doing differently than the rest of the population. It is just really difficult. It requires a real effort to understand what people are really going through. And by the way, that's made worse by who we are. This is political leanings of academics in this country. Far left, left, middle, right. 10% of academics, this is professor's associate assistant, 10% of academics identify as right. Far right, forget about it, driven out the way extinct species, driven out. By the way, 50% of the country is right. The only other industry that is more ideologically homogenous to the left than us? The media. Only 6% of people in the media identify as right, which is enormously different than the country. This is a problem. This is a problem because we do not understand how the other group thinks. So, we in public health, for us in public health, to get all high on our horse and say, can you believe those people, they don't want a mask? Well, those people, quote, are people. And they are the population that we mean to serve. And that population was ill served by us. And it's time for us to actually ask these hard questions. Just to talk red and blue for a second, this looks at percent of people who actually live in bubbles. The bottom line, the red is Republican, top is Democrat. 38% of Democrats live in a bubble. Bubble means that 100% of people are also Democrats. About 19% of Republicans live in bubbles. When everybody is like you, that is a very particular view of the world. And I think we need to be aware of this to learn how we can do better to truly represent populations. There's other different ways of looking at this. This is epidemiologists today, where about 70% of epidemiologists are white, including white and Asian. We have about 85% of epidemiologists are white or Asian, but far smaller numbers who are Hispanic or Black, which of course gives you a different perspective. And then just to give you a particularly egregious example of our particular view of the world, when you read the medical literature, this is the medical literature, this is the number of publications. This is cancer, but it actually applies equal well to everything. So this is the number of publications published in the world in 1 year. On the right, look at the bottom right, number of those publication outputs with authors from low and middle income countries. 6% of papers published have authors from low and middle income countries. 6%. You know what percent of the world is actually in low and middle income countries? 83%. So our scientific literature, right, which is supposed to be the body of generalizable knowledge on which we base what we say, is actually comes from 6% of authors are coming from places which represent 82% of people. That's just an enormous mismatch, right? Do you think that then means that we are looking at the world scientifically the way we should be looking at the world? Probably not, right? I've published about this. I've been sort of trying to push that we should be clear about these biases. This means that we should push for diversity in what we do. We need to learn to be open and honest in our conversations, something which we're not very good at. Next time within your school of public health, there is an outcry about somebody voicing something which is different than the community's general norms. Perhaps think about this and say, are we actually truly open in our conversations? I'm going to conclude. This is costly. Like being not preventing disease costs the world, not just from a health point of view, but from a political point of view. Like this country has been riven by divisions in the past almost decade now, 7-8 years. The world has been riven by divisions, and a lot of these political divisions actually come from poor health. Just to show this particular slide, which I find quite remarkable. The x-axis is counties. The bubbles are counties. This is change in life expectancy in a county. On the right, it means you're living in a county that was doing better, gaining life expectancy. On the left, county that's doing worse in life expectancy, right? On the y-axis, percent of the vote in that county for candidate Trump in the election between Trump and Clinton. What you see is clear dose response, right? People who are doing healthier vote for Clinton. People doing less healthy vote for Trump. And this is, I want to be clear, this is a nonpartisan comment. Okay, it's actually very simple. There were two candidates running for election. One of them said things are doing well, vote for me. The other one said everything's going to hell in a handbasket. I'm going to rip up the playbook, vote for me. it's to me, it's entirely rational to vote for the candidate who says everything's going to hell in a handbasket if actually you're living in a county where your health has stagnated over 40 years, right? So health really drives how people see the world. And by the way, this is not just the US. There's actually various, almost exactly the same analysis done in European countries. When you have very bad health, you actually end up with populists getting elected because they say that we're going to change how we do things. So we in health have a real role to play in shaping the kind of world that then we choose to live in. So just to conclude, I just want to conclude with two last stories. And then I'll wrap up. I want to, first of all, say, well, so all of this is sort of obvious, right? So therefore, because it's obvious, it's clear, and we're all going to do it, right? Well, let me go back to perhaps the most consequential public health discovery of all of modern times in the past 200, 300 years. Probably the most consequential public health discovery of the past 300 years is hand washing. Hand washing has saved countless millions of lives around the world. The original data on hand washing came from this guy, Ignaz Semmelweis. He was a physician, and he actually observed that there are two clinics, the blue line and the pink line. The pink line is the first clinic where women were dying right after childbirth, and the blue line, they were dying much less, as you can see in the 1840s. Ignaz Semmelweis observed that the women who were dying more in the pink clinics were being delivered by doctors. Women who were dying less in the blue clinic were being delivered by nurses. He further observed that the doctors were doing, it happened to be the same floor where labor and delivery was as where what autopsies were. Doctors would be doing autopsies with their hands and then go in without washing their hands and go deliver babies, and the women were dying. So he said we should wash our hands and we're going to save people from dying. It was obvious, it saved millions of lives, and Ignaz Semmelweis was celebrated, became a public health hero. Now, everybody laughed at Ignaz Semmelweis, said he was completely wrong, said he didn't know what he was talking about. He lost his position in the hospital, and he eventually died penniless in, at the time, what was called an insane asylum. So the most consequential public health discovery of the past several hundred years, the person who actually articulated it went nowhere. So I think it's important for us to recognize that radical thinking about how we should do things better is not always welcomed by us or by the world, which means it makes it even harder to make sure we do it right. Last point, because I know I've given you some things that are downers, I want to end on a high. So to end on a high, I want to end on with a sports metaphor, because sports. I immigrated to this country, and I immigrated to this country in no small part because this country has the world's best sports team. Anybody know what that is? The U.S. Women's National Soccer Team, which has there's been no other team that has been as dominant as they were until recently, the past couple of years. So apparently, they're going to be good again in the next year. So briefly, for those of you who don't know soccer, it's played with 11 people one side, 11 people on the other side, and they try to score in each other's net. They only use their feet. That's why it's called football, real football. But there is one player, and she can use her arms, her legs, her whole body. That's the woman in black in the middle of the Sanair. And if nobody scores on you, you never lose, okay? So if I say to you, here's how the game is played, roughly I'm going to give you $1 billion, create the world's best soccer team, you might say, nobody scores on me, I never lose, so maybe I should just invest in a goalkeeper. Get $1 billion, invest them all in a goalkeeper. But if you watch a professional soccer game and you see what the goalie's doing, you know what she's doing? She's walking around her net, being very agitated and yelling at her fellow players all the time. And you know what she's yelling at them? Then keep the ball away from me. Because anybody who's ever been in a soccer field and been under net knows the net's pretty darn big. And if the ball comes at you fast enough, somebody's going to score. Okay? So why am I saying this? The metaphor is, the goalkeeper is medicine. It's what we do. Like, if we get sick, we want a good goalkeeper. You want a good goalkeeper to try to save the ball. But in order to generate health, you need all the other 10 players. You need to move the ball upfield. The other 10 players are things I'll talk about today. It's paying attention to health equity front and center, paying attention to human dignity, paying attention to things like gender equity, stable housing, livable wages, clean air, drinkable water, and a science that is responsible and responsive, engages communities, and embraces the imperatives to create political will. That is what we should be doing. And that, I think, is what reimagining prevention means like going forward. I will stop there. These are QR codes. One of them leads to a book, which I have coming out in the fall. The other one is to a blog, which I put out roughly every couple of weeks. For anybody who's interested in reading more, I will be delighted to take questions from in person or from online. Thank you for having me.